Laryngeal nerve injuries result in a variety of symptoms and disorders, reflecting the anatomy of the innervation of the larynx. Injury to the inferior laryngeal nerve or to its parent nerve, the recurrent laryngeal nerve, results in paralysis of most of the muscles that move the vocal folds. The recurrent laryngeal nerves are especially vulnerable during thyroidectomy, and the left recurrent laryngeal nerve is vulnerable during procedures performed or when pathology occurs involving or in the vicinity of the aortic arch. Clinically, the vocal folds are examined through a laryngoscope, providing a superior view. Normally, the two folds converge bilaterally and simultaneously toward the midline. In a unilateral injury, the voice is initially poor because the paralyzed vocal fold cannot adduct toward the contralateral vocal fold. Within weeks, muscles of the functional side compensate so that the fold of that side crosses the midline to adduct against the paralyzed fold. In a bilateral injury, the voice tone is almost absent, as the vocal folds remain motionless in a position in which the gap between them, the rhymaglottidus, is narrower than usual, resulting in stridor, high-pitched, noisy respiration. In progressive lesions of the recurrent laryngeal nerve, abduction of the vocal folds is lost before adduction. Conversely, during recovery, adduction returns before abduction. This is a reflection of the number of muscles involved. There is a single abductor, the posterior cricoarytenoid, while multiple muscles contribute directly or indirectly to adduction. In serious disorders of the larynx, such as carcinoma of the vocal folds, hoarseness is a common symptom. Injury to the internal laryngeal nerve or its parent nerve, the superior laryngeal nerve, results in anesthesia of the laryngeal mucosa, superior to the vocal folds, thereby diminishing the protective mechanism designed to keep foreign bodies out of the larynx. Injury to the external branch of the superior laryngeal nerve results in paralysis of the cricothyroid, resulting in a monotone voice as the paralyzed muscle is unable to increase the length and tension of the vocal ligament to increase the pitch of the voice. In order to avoid injury to the external branch of the superior laryngeal nerve during surgery, the superior thyroid artery is ligated and sectioned more superior to the gland, where it is not as closely related to the nerve. Because an enlarged thyroid gland, goiter, may impair innervation of the larynx by compressing the laryngeal nerves, the vocal folds are examined laryngoscopically before an operation in this area. In this way, inadvertent damage to the larynx and its nerves during surgery may be distinguished from a pre-existing injury resulting from nerve compression. Knowledge of laryngeal anatomy, especially with regard to the course and relationships of the motor nerves, is vital to diagnosing laryngeal dysfunction and preventing iatrogenic injury.